All right, so today I'm going to kind of just give an overview of kind of how to, just kind of the relationship between alcohol misuse and daily prescription opioid use or medication-assisted treatment. This will also involve talking about pain when thinking about these relationships as well. Just a brief overview. So we'll talk about some prevalence statistics, some complications about regarding the interaction between alcohol and opioid use, so the relationship between pain and alcohol use, more from an observation epidemiological perspective, brief overview of neurobiology of their relationship, and then some assessment, broad assessment and intervention ideas. So, some recent statistics that I found through the Drug Abuse Warning Network, I think this is from 2016, that alcohol was involved in about 18.5% and 22% of opioid-related ED visits and deaths, respectively. This included both prescription and non-prescription use of opioids, and that's just broad adult population. ED visits were highest among individuals aged 30 to 50, and both of those age categories, and then deaths were highest in a slightly older group of categories. Alcohol was also involved in about 10-11% of buprenorphine and methadone related visits. So obviously there's going to be, I think there's some, incidents here that's notable and worthy of, further assessment. As we all know, there can be some pretty severe complications between alcohol and opioid use. We know that excessive use of opioids, can lead to respiratory depression. There's opioid receptor action in the brainstem that can affect respiratory rhythm. Alcohol being a central nervous system depressant, obviously can exacerbate respiratory effects. And there's also evidence of cross-tolerance. There's research, particularly in rats, showing anti-nociceptive effects of opioids when they're addicted to alcohol. So that can increase the, someone who's using alcohol, that could increase their risk for excessive use of opioids if they're not getting the effects, the pain relieving effects that they initially were prior to their change in alcohol use. So kind of looking at the relationship between pain and alcohol, you can look at it from a general population perspective or a pain population or a substance use disorder population. So the statistics kind of differ depending on how you kind of zoom in. Broadly, we know that just alcohol use in general has direct effects on pain. Excessive use over, an extended period of time can induce, abdominal pain, chronic pancreatitis, peripheral neuropathy, chronic joint pain, increased risk for traumatic injuries and falls. So there's just direct effects of alcohol on pain due to excessive use. When you look at back or neck pain patient populations, they're up to 2 times more likely to have an alcohol use disorder. When you look at an alcohol use disorder patient population in residential treatment, they tend to report more moderate to severe pain than individuals in comparison groups that aren't in residential treatment or don't have an alcohol use disorder. In general, population estimates show that moderate alcohol use may be associated with reduced likelihood of chronic back or neck pain and rheumatoid arthritis. The mechanism there isn't fully understood. That may mimic or sort of shadow what we see sometimes with moderate alcohol use and cardiovascular effects and also in certain domains of cognitive functioning. Alcohols are carcinogens, maybe that's all new. Acute alcohol administration may decrease pain. In experimental settings, they really only find that effect in problem drinkers or alcohol or patients with use disorder. And that's sort of consistent with the idea too that there's reports of increased pain, particularly if they have a pain disorder already, but just the increase in pain, both emotionally and physically during withdrawal. And, alcohol can serve as a negative reinforcer if pain is there, as a way to mitigate pain and can, increase risk for relapse if someone has a use disorder. So this is sort of speculation on this group, kind of modeling a curvilinear relationship between alcohol and chronic pain. This hasn't been fully, articulated and described in the literature, and there's a lot more work that has to be done, but it's something to kind of keep in mind. And I'm not going to go through all the points here, but basically they're taking a non-committal approach and deciding, hey, like, there's lots of factors here. They're kind of related bidirectionally. Broadly, if you look at the top left-hand corner, low to moderate use can, if you go to the right-hand corner, can lead to positive pain characteristics and reduce likelihood of pain. And those intermediate factors like decreased fear avoidance, maybe because of the alleviating effects of moderate use, they're less inclined to avoid value-driven activity, so they're increasing meaning in their life. There's increased social facilitation, both because of the alcohol use or in the context of alcohol use, who knows. And it can be a stress reliever, I guess, in some contexts, particularly the social piece or just social function in general. And then on the other extreme, down at the bottom left-hand corner, you see alcohol use or excessive alcohol use can lead, all the way to the right-hand corner, negative pain outcomes. And, possible bidirectional factors could be, altered pain reactivity, interactions with their pain treatment, whether it's, in terms of their medication or adherence to other sort of parts of their plan, and then, more acute injuries and other long-term health effects. So that this fully has to, again, be further defined, but it kind of gives you a sense that it is quite complex, the relationship between pain and alcohol.
There's also a piece, I think, around tobacco, because almost all severe AUD folks smoke.
Yeah, right, good point.
And so there's an overlay there as well that has to need a great deal more exploration.
Totally, yeah, good point, yeah. Definitely. And we can look at, we can zoom in a little bit more into some of the neurobiology. I'm not going to get into all the pathways on it, but I think if you think about alcohol use, pain, and even negative affect and emotional functioning, if you look at those three sort of tripartite areas in terms of their neurocircuitry, you find that they overlap considerably, and there's a lot of crosstalk between them. And the kind of understanding is like there's an allostatic load that will eventually lead the person to dysregulation in one or more of those three areas. So if you look at the bottom right-hand picture of the brain, let's say you get a pain stimulus through the dorsal root ganglion, it comes up efferently into the brainstem and into lower limbic structures. You see the AMG in the red there, that's the amygdala. That's sort of a nexus point. The amygdala overlaps in pain processing, addiction, and obviously affective functioning. And there's, interconnections between all of those circuitry, types of circuitry, that if one becomes dysregulated, it could potentially, in theory, dysregulate the others over time. If you go to the left-hand diagram, you can see that alcohol intoxication leads to reward. Maybe there's some rewarding effects. There's decreased pain, but over time, excessive use, changes in dysregulation in these various networks can lead to, again, dysregulation and impulse control, effective functioning, leading into increased pain and whatnot. So, again, take home is that it's quite complex, and that dysregulation in any of these neurocircuitry models can affect the other or a combination of the other. And therefore, each one is somewhat of a risk factor. So screening and assessment. Okay, so we know that a prior history of substance use disorders can be a risk factor for misuse of opioids. So if someone does have a history of alcohol use disorder, whether it's controlled or not, even if it is controlled, that still puts them at risk for later opioid misuse, particularly if there's other complexities in their their life. More acutely, and this, I don't know how often this happens, this hasn't happened in my experience, but if someone, you can tell if someone who's, on an MAT or on a opioid prescription plan is abusing alcohol, if they come into the clinic and you notice somnolence or stupor, meiosis, changes in breathing. I don't know if anyone else has had that sort of experience. You have? Okay.
Had positive urine spurt.
Oh, okay, sure. So, in general, if there is any suspicion or there's, clearly overt markers of changes in one's alcohol use, if they're on some sort of opioid, I think increasing the opioid testing for opioid biomarkers is important because that could generalize the alcohol use, or change in alcohol use could generalize to misuse of other substances. To your point, like other urine screens and other, liver testing could be helpful in determining if alcohol use has changed in your patients. And of course, checking the PDMP more regularly, even if that person doesn't have a history of misuse of opioids, maybe things are changing in just terms of their whole misuse profile. So it wouldn't hurt just to check. And, I think some of the screening assessment, I think we're all familiar with, but it may be time to reevaluate or re-engage some of these measures with somebody who you suspect a change in their alcohol use. So our basic audit cage, I think investigating if there's a change in their emotional state, either in terms of negative depressive affect or anxiety, thinking about trauma, both if there's a new acute incidence of trauma in their life, or from a more adverse childhood experiences sort of perspective, has something been reactivated from their past, or hasn't really been examined and now it's coming to the surface because of whatever other psychosocial stressors that, maybe, the person's trying to use alcohol to, treat any one of these sort of symptoms. The 5 A's, I'm sure we've all heard of that. So I think a good take home, as we all would agree, that and to your point, Rito, like engaging the patient in a respectful manner initially. You don't want to shut them down in a way that hopefully leads to honoring and really leveraging their, their sense of agency and, and their own understanding of their, misuse of whatever the substance may be, or their change in how they're dealing with their pain. So we don't want to shut them down on any of these factors. So we really want to keep this open and, keep it and maintaining a relationship where there's open and free disclosure. If you want to zoom in more and take more of a try to get more of a detailed assessment of their pain or change in their opioid or alcohol use, a functional analysis can really help guide that by examining the internal, like the emotional, psychological aspects, as well as the broad environmental and external aspects of their either change in use or their change in how they adhere to their pain management plan, and whatever those, and also in terms of identifying those triggers. So in what context, with whom, what are they feeling in these moments leading up to this, to whatever their use or change in pain functioning is. Reassessing the pain is really important in this moment if they have a pain history, or even if they don't. Maybe they're experiencing pain, a new onset or acute onset of pain for whatever reason. So reassessing pain function, their adherence to their plan, getting a good sense of their understanding of their pain, what they think the driving factors are of their pain. Are they catastrophizing? Do they have realistic expectations? Do they think they should be completely absent of pain versus, are they at a point in their, their pain history where they have to accept a certain level of pain to function? Are they engaging social support? And is the quality of their social support present? And are there supportive factors around their pain particularly? And, always allaying the patient's fears that, if they are in an MAT or some sort of opioid prescription plan, that, we're gonna still treat your pain. That may have to change depending on the severity of the alcohol use, but we don't want to increase, additional stress on them. Ideally, if there's interdisciplinary pain or substance use, treatment program, that would be ideal. Oftentimes there isn't, so I think we would all agree, as our model suggests here today, that increasing communication across specialties is important when feasible. That's a lot to manage, understandably. And I think you have to take a broader multimodal approach that's going to involve education, possibly more physical interaction around the pain, like physical therapy, other types of medications that are non-opioid related, other types of treatment environments. And then, in the room, if you're doing behavioral work, it's very much a multimodal integrative approach, at least the way I work in the pain clinic here at UW, where any number of these sort of approaches I'll pull from my tool belt, either simultaneously or at various points along the course of their treatment. So you have to really do a really detailed assessment across a number of domains. There's psychosocial functioning, psychiatric functioning, pain, and alcohol use disorders, or alcohol or substance use history. So you have to see how all those factors interact. And then, of course, there's medications that, can, in conjunction with psychosocial treatments, I think be effective. I don't have a lot of experience working with patients on Camprosate or naltrexone. I'd be actually really curious if anyone has any interesting anecdotes on successes with those medications in addition to other treatments in the context of pain particularly. So that's about all. So if any questions, we have time for this, a few minutes for a discussion.
I think what you touched on with the multiple approaches and an integrated team approach is a really huge piece. Do you use any mixed practice chiropractic too or not?
Not in the UW system, but a number of my patients will have that as part of their.
We've had patients report good success with that. That's part of what I asked.
Oh, cool. Yeah, no, I'm all.
Where they're doing the nutrition and all of those pieces. I mean, it's a holistic.
Our pain, at least at UW in the pain clinic, we have a physical therapist now who's joining them, and then we're actually bringing in our addiction medicine fellows more regularly next year. In addition to the behavioral work that I'm doing. But yeah, no, I think that would be awesome.
Because when you have this kind of presentation, there are so many elements to it.
Oh, yeah.
And oftentimes the person may start out looking for the right medication, and it's just not about the right medication. It's about all of those things. Mm-hmm. So I think the more that we work together to move, particularly with patients that kind of fit this profile, to move to this multi-focus, integrated approach, the better outcomes you'll have. Because this is also a group that's high risk, particularly as they get a little bit older, high risk for suicide. When you add the alcohol in there, this is a really high profile. Yeah, absolutely. So if there's a sense that there's no hope, yeah, this is a patient that will be at high risk for that. So.
Thank you.
So I think you touched a few points that are very important, and one that I like to ask my patients is about the pain. How functional are you with your pain?
Focus on function.
And because we see that patients on chronic opioids for pain, when you ask the scale of 1 to 10, the scale never goes down. I mean, you go up on the opioids and the scale never goes down. But you ask them, are you able to go get the mail? Oh yeah, I am able to do that now. So I usually ask more for the functionality of the patient than more than the scale.
Yeah, a lot of the behavioral treatments, particularly evidence-based ones, are focusing more on can we increase their value-driven activity, right, amidst their pain.
Plus modifying even when they say what their goals are. Pain-free isn't on the table. Yeah. But rather that functional goal, I want to be able to play with my grandkids or something like that. So, it's very.
The other point is that it's also important to tell the patient that no matter what, if we decrease their opioids or if we are asking them to stop using alcohol, that their pain is going to be addressed. Because like you said, that brings anxiety. When you tell them, oh, you're using alcohol, we want to keep you safe, now we're going to decrease the opioids. So they feel, a lot of anxiety with that. So it's important to...
Because we lost our
Sign.
So one other question. Oh, yeah, Ritu, go ahead.
Yeah, so one thing that I wanted to just add, I think is great discussion and great ideas to keep the pain piece addressed in different ways as another off-label sort of approach. Yeah, I think we've made a statement with the echo. It's echoing. Baclofen is another off-label medication that can be quite helpful for alcohol use disorder and help with the muscular components of pain as well, and doesn't seem to sedate as much. People seem to find that it's quite helpful without impairing the daily function, and then especially if you have people that are in other manual labor trades anyway, sometimes that can provide added benefit and help keep people away from the alcohol for the urges for it from the pain aspect. And then, of course, there's that book by that guy Olivier about Heal Thyself, who talks about his use of baclofen for treatment of alcohol use disorder, which sort of started all those studies. So those are some resources. And then, I don't want to sound like I'm just a one medication doctor here, but the antabuse here may also be an option to consider depending on your concern for risk of the overdose and especially the worry of concomitant use, alcohol and opioids together.
Actually, that's the other thing I was going to ask about. Anybody where this is identified, they really need Narcan, and they and their family need the education.
Yeah.
Absolutely, because they don't have to have an increase in their opioids to be at risk of overdose. So at least reversing the opioids would help.